A 55-year-old man comes to the emergency department with fever, cough, and shortness of breath for the past 3 days. He reports producing thick, yellowish sputum and complains of sharp chest pain that worsens when he takes a deep breath. He feels weak, has chills, and says the symptoms started suddenly. On arrival, he looks ill and febrile. His temperature is 39 degrees Celsius, heart rate 110, respiratory rate 26, and oxygen saturation 90% on room air. On lung examination, there are crackles over the right lower lung field with dullness to percussion. His white blood cell count is elevated, suggesting an acute bacterial infection. A chest X-ray shows a lobar consolidation in the right lower lobe. These findings are classic for typical pneumonia, most commonly caused by organisms like Streptococcus pneumonia. Typical pneumonia usually presents with sudden onset fever, productive cough, pleuritic chest pain, and focal findings on imaging. Now contrast this with a different presentation. A 30-year-old woman presents with a dry cough, low-grade fever, headache, and body aches for 1 week. She feels tired but is still able to work. She denies chest pain and produces little to no sputum. On examination, her vital signs are only mildly abnormal and lung findings are minimal. Her chest X-ray, however, shows diffuse, patchy interstitial infiltrates rather than a single lobar opacity. This presentation is typical of atypical pneumonia, often caused by organisms such as Mycoplasma pneumonia, Chlamydophila, or respiratory viruses. Atypical pneumonia tends to have a gradual onset, milder symptoms, dry cough, and extrapulmonary features like headache or myalgia. Distinguishing between typical and atypical pneumonia is important because it guides antibiotic choice. Typical pneumonia responds well to beta-lactam antibiotics, while atypical organisms require macrolides, doxycycline, or fluoroquinolones. Key takeaway: sudden high fever, productive cough, and lobar consolidation suggest typical pneumonia, while gradual onset, dry cough, mild symptoms, and diffuse infiltrates point toward atypical pneumonia. Recognizing the pattern ensures appropriate treatment and better patient outcomes.